Good evening, everyone. I'm Dr. Stephanie Correa. I'm the owner and founder of Animal Cancer Care Clinic, and I'm so pleased to welcome you all tonight to the last session of the 2022 Animal Cancer Care Clinic Summer Webinar Series. We made it. We made it. So we want to express our appreciation to Merck for hanging in with us through the summer. And certainly, we want to thank you all for being here tonight, for being here for the last 3 sessions as well. So thank you for your support. We are really pleased to be able to do these sessions for everybody. So every time I participate in a webinar session like this or in a CE event, I am reminded of the value of coming together as a group of veterinarians and being a part of these events. You know, the things that bind us together, the things that we share in common. And I think you guys can all identify with this, but today, as in many days, I was in the clinic and I was in a situation with a client and a patient, and I sort of stopped for a minute and looked and thought to myself, you literally cannot make this stuff up. I mean, some of the things, and I know you'll agree with me, that happen to us, you can't make it up. And, you know, that brings me to a special event that we're going to be hosting. My friend, Dr. Renee Alsaraf, agrees that some of this stuff you just can't make up, and you've got to write a book about it. And she did. My good friend, Dr. Renee Alsaraf, veterinary oncologist, wrote a book called Sit, Stay, Heal: What Dogs Can Teach Us About Living Well. And what we're going to do is we're going to hold a book signing event in November in our Orlando and in our Fort Lauderdale hospitals. And Renee is going to come and she's going to join us. And she's going to talk to us about what inspired her to write this book and what inspired her with the situations that we find ourselves in and the dogs that we care for. So it's going to be a lovely event. We're going to have food and a wine bar and music and hospital tours. We're going to hold the event on November 8th in Orlando and on November 10th in Fort Lauderdale. So please join us. Dr. Renee's going to speak to us, and everybody's going to leave with an autographed copy of her book, which is due to be released in October and is actually projected to be a bestseller. So look for the invitation. You'll find it in our newsletter, our Dose of Hope newsletter, which will be coming out the first or second week in October. So when you see that invite, if you're interested and you want to come, like I said, it's going to be a lovely event. Go ahead and RSVP because space is limited. So as you all know, and as I talk about, cancer is what we do. Our entire team works diligently every day to deliver hope to your clients and animal patients. And for us, hope is healing, optimism, patience, and empathy. And this attitude and caring approach, the way we practice, for us is just as important as our highly trained specialists and our advanced technology and our decades and decades of cancer care experience. So thank you for trusting us with your clients. Thank you for trusting us with your animal patients. Remember that the best way to get a patient to us is to use our referral portal, cancercarereferral.com. You log on to that, you enter the client information, the patient information. You can upload medical records right there, send that information to us, and we will take it from there. We will call the client, we will get them scheduled. So moving along, it is truly my pleasure to introduce Dr. Jared Lyons, a board-certified veterinary radiation oncologist who joined our practice about 18 months ago. And I will tell you, his expertise has been invaluable to our practice. Plus, he's just such a nice guy, you'll see. I mean, he's just lovely to the clients, to the patients. He cares. he's been practicing almost as long as me. So that's also nice for me to have somebody with all his breadth of knowledge and experience. He's advanced the field of veterinary radiation oncology through his published materials, clinical trials, lectures, blogs. He's also just a neat guy. I mean, he's an inventor and a carpenter and also an author of Survivor, The Dog Days of Cancer. It's a loving book about a dog going through cancer treatment. So please join me in welcoming Dr. Lyons. He has put together a very interesting lecture for us about mast cell and soft tissue sarcoma and radiation therapy. So welcome, Dr. Lyons.
Thank you so much, Dr. Correa. I really appreciate it. Thank you, everybody, for joining us this evening. So I'm going to talk about mast cell tumors and soft tissue sarcomas. And these are pretty much one of the most common types of skin tumors that we see in our practice every day. So, mast cells are cancers of a white blood cell origin. They play a role in allergic responses, and they account for about 14 to 21% of all skin tumors. Our mast cells, as we all learned in vet school, help us against parasitic infections and tissue repair and formation of new vessels. One of the things that we also find is they can degranulate, and that releases inflammatory mediators, helps with the immune system. It's heparin and histamine. And when we do see degranulation, sometimes that can get us also into trouble. And we'll talk about that in a little bit. So like everything, and like I tell all of my clients, I don't know what causes cancer: environment, food, genetics, genetic mutations. We don't know. There's some mutations in the protein c-KIT, tyrosine kinase receptors. That's been found in about 25 to 30% of tumors. And at the end of the day, we don't know. I just say it's bad luck. So certain breeds are more susceptible and definitely overrepresented. I put a picture of something I hardly ever see, which is a puppy, not a boxer. So one of the breeds some of the breeds that we see: boxers, beagles, bull terriers, labs. Some are reported to have an increased probability of developing mast cell tumors, and I listed them there. And then we get into the different schemes. And I've been doing this for a little bit of time. I am more in, I like the old scheme better, but the new scheme does have its uses. So the two different schemes really are the Patnick one from Vet Path back in 1984, and grade ones were well differentiated. You guys can read that, but I'll just say in general, these things are very locally aggressive. They don't like to spread. We don't worry about them too much. I jump to the grade threes because what we know about those are they can unfortunately have about a 50 to 92% chance of spread. They tend to be pretty aggressive both locally and unfortunately systemically as well. And then we have the grade twos, which at the end of the day can do whatever the heck they like. There are some things that give us more of an indication whether they're going to act like the grade three or the grade ones. One of them is the mitotic index. And so the magic number that they've reported is if it has a higher than 6 or greater than equal and higher 6 of 10 mitotic 6 mitotic figures per 10 high-powered fields, then we get worried. If it's below that, then it's theoretically more likely to be more low grade. But I can't tell you how many of these that have come into the clinic that were low grade 2, 0 mitotic index, and the dog has lymph node metastasis, and the thing came back after 3 weeks. So as much as we think we know, we're reminded about the practice of medicine. It is truly a practice right now, but it does give us some guidelines. Of course, what doesn't fit into here are the subcutaneous mast cell tumors, which we'll cover in a little bit. So the other grading scheme is the Kippel grading scheme. And this differentiated it just into high and low grade. And what Kippel did is she went according to the mitotic figures. If it was less than 7, also multinucleated cells, bizarre nuclei. I love that bizarre part about that, which is defined as highly atypical with indentations and other criteria. That defined a low grade. And then you had the high grade. And the high grade, as you can read there, it's greater than equal to 7 per 10, and everything else that's listed there. And then also we have the nice category of subcutaneous mast cell tumors. And in general, subcutaneous mast cell tumors tend to be locally invasive, and they usually have a pretty low rate of systemic spread. Less than 5% or even a little bit more than 5% will spread. So when I read a subcutaneous, if indeed it does follow the literature, I'm not as concerned as I am if it's one of the grade 2 or grade 3s. That being said, we always get the ones that don't really listen to what they're meant to do. But a good paper that did come out, and I just didn't actually list it, did show that the majority of these, even if you don't get margins, don't come back. That's not to say that I don't recommend adjunctive therapy afterwards if I'm worried, and that's reading a lot of the different things that I've said above about the histopathology. But the gist of it is that if it, they should theoretically not be as aggressive. So some of the prognostic factors that have been listed, there's a lot of them. A lot of people got their names on papers to do this. Grade, stage, location. I'm a little more old school, so I still believe somewhat inguinal and abdominal may actually be a little bit more invasive. The agnal, the PCNA, the Ki-67. There's the mast cell tumor prognostic panel that you can order to further differentiate it as well. Ploidy. I mean, there's a bunch of different things that define it. But at the end of the day, as I said, cancer is cancer. It does what it wants. So one of the things that has been listed as stage, I don't really use stage, to be quite frank with you, but it is listed, so it's worth mentioning. Stage 0 is if it's on the skin surface and it is incompletely removed and there's no lymph node mets. 1 is if it's in if it's one tumor, at least on the skin surface with no lymph node involvement as well. Stage 2 is on the skin with lymph node involvement, the draining one. Stage 3 is multiple skin tumors with or without lymph nodes. And stage 4 is anything that has distant metastasis. And you have substage as well. As I said, I don't really use stage. Now, staging, different thing than stage. What I always recommend is when the dog comes in and it has a mass and you want to find out what it is, and you suspect a mast cell tumor, if there's any suspicion whatsoever, you're not going to lose anything by pre-medding with Benadryl and Pepsid. I just think it's a good idea. I have had some where you've aspirated this small little thing and they can call you the next day to tell you that it's still bleeding and it's not going so well. So one thing is an aspirate of the mass to get a diagnosis. You can look at it in-house as well if you're comfortable doing that. Obviously, blood panel, urinalysis included. Aspirate the draining lymph nodes. So if it's on the front legs, go for your prescapulars. If it's on the facial area or the head, go for your mandibulars, potentially your prescaps as well as go for your popliteals if it's on the back leg, distal to where the popliteals will hide out. So the other thing definitely is an abdominal ultrasound. Now this is if it's, I always do ultrasounds of all my mast cell tumors as long as that we don't know the grade. And still grade 2 and grade 3s are still in the running, or if they're proven to be grade 2 or grade 3s, we do an abdominal ultrasound. As far as aspirates of the spleen and liver, a little controversial, depending on what you want to do. If you really want to dot the I's and cross the T's, no matter how it looks, you aspirate the spleen and the liver, or you aspirate any splenic or liver nodules that you find. There is a small proportion of them that you'll just aspirate and get lucky or unlucky, unfortunately, and find that there's mast cell tumor disease in the liver or spleen. We used to do bone marrow aspirates. I don't know anyone who's doing that anymore. I don't really do that. And then I don't do thoracic radiographs. These usually don't go to the lungs. So unless you're suspicious of anything in the chest or cardiomegaly or the dog has a heart murmur, I don't use thoracic radiographs specifically for mast cell tumors for any type of staging. They don't go to the lungs. So treatment options. Like any mass, ideally, if you can surgically remove it with wide margins, then you're golden. That's one of the best things you can do. Traditionally, the surgical recommendation when you're going for the surgery is greater than 3 centimeters laterally and 1 tissue plane deep. There's been different opinions on that. We've gone backwards and forwards. I feel that we used to want to do that, and then for like 10 or 15 years, we modified it. And now there's some more recent literature that's coming back to say and go a little wider. So something back in 2020 showed that several studies, they actually analyzed a bunch of different studies and tried to come to some sort of a conclusion. And the objective of this one is to determine if resection with lateral surgical margins less than 3 centimeters resulted in lower rates of incomplete excision and local tumor recurrence. And what they came to is that if you did 2 centimeters or 3 centimeters, that was associated with comparably lower rates of incomplete excision and recurrence, which seems pretty obvious to me, but there is some use to that. Recommendations on that, in general, is subjective. In something from 2011, 96% of animals did not have recurrence if margins were greater than 10 millimeters lateral and greater and equal than 4 millimeters deep. And there's a breakdown of how many of each of the different grades there are. Yeah, if you look for mast cell tumors papers, you're gonna get a lot of data, and sorting through them is often sometimes difficult to do. But this is some of the information that's out there. We're going to skip that slide. That decided to jump in there way ahead of its time. So treatment options as well, continuing with that. So like anything, if margins are incomplete and it's a grade 2 or above, or margins are narrow, the recommendation is, and not that I'm biased or anything, but it's radiation therapy. So especially in certain locations, in my mind, inguinal definitely, the muzzle also has been shown to be a little bit more invasive. Toes, definitely. There was some push not to do radiation therapy because in some of the surgical papers, they said, well, surgery alone, you got an 82% rate of not having this come back, and some papers even 90. But the problem is I see a lot of the ones that are not meant to come back. And so what I always recommend to referring veterinarians is at least throw it out there. At least say, hey, margins were narrow. Theoretically, this shouldn't come back. We're not that great at data acquisition yet in the veterinary world. So here's an option. Maybe go speak to the oncologists, ask, is this something that we want to do? And if you can lower the percentage of recurrence, to less than 4% or 3%, then I think you're definitely, you're doing well on that. So also for mast cell tumors, we recommend systemic chemotherapy for high grade 2s and grade 3s. Also for some non-surgical tumors or frankly metastatic disease as well. As far as radiation therapy, just a brief synopsis, I won't get into too much of it, but in general, we want to treat when we do conventional radiation, at least 3 centimeters in all directions. Radiation goes deep, so it goes where surgery cannot, including the deep margin. And so it's definitely something in this that I represented. You have the gross tumor in the margins, and that's our good way of treating anything around it. We use radiation for non-resectable tumors, post-surgical therapy, incompletely resected microscopic scars, as well as in some cases, we do radiation ahead of actually doing surgery. And it's something that definitely can decrease the potential for recurrence. Radiation therapy is also used in palliation. And for my non-resectable mast cell tumors, radiation therapy in the palliative setting is a great option. I personally like them to see chemotherapy first for those non-resectable tumors. But if chemotherapy is failing or just not doing what we want, or we've already gone through the different protocols and they have recurrence, I definitely think that that is a case where we should offer radiation therapy. So we know radiation is very good at mast cell tumors. They're very radio sensitive. They respond very well to radiation. Just here's a study that was presented in 2004 with 35 dogs. They got palliative radiation therapy. Gray is just a unit of measure, like a millimeter or an inch or whatever, but with energy, fraction just refers to how many times we did it. So 4 fractions times 8 gray means we did 8 gray on day 0, 7, 21, and 28. We did prednisone, and lo and behold, 88.5% of them responded. And in this, the progression-free interval was 34 months. We won't go into what grades they were because it's a mast cell tumor study and it's pretty much all grades. So the other thing that I'll mention here is radiosurgery, because once something's removed and you don't get margins or you got a scar left over, you can do radiosurgery instead of your conventional month of radiation with 2 weeks of side effects. Now we can do it in one big dose, and I'll come back to that. In this slide, I'll come back to it, it seems. So anyway, for radiosurgery, the gist of it is that you are giving what would normally take a month to give, and you're doing it in anywhere between 1 to 3 doses. For the skin tumors or the skin scars, I actually do it in 1 dose. We will miss the first 3 or 4 millimeters of skin because either you took that off at surgery or it wasn't on the skin surface. And so we're treating about a 1 to 1.5 centimeter margin around it. We usually don't get side effects, which is awesome. And the normal tissues are our limiting factor. But that being said, it's a 3-dimensional thing. We can minimize any real side effects. And for our grade 3s, we can get them to chemotherapy a lot sooner. And the clients really only need to come in 1 or 2 separate times, no real side effects. And the results are fantastic. It's a whole new world. So definitive radiation therapy for mast cell tumors, as I said, grade 1s we don't do unless it's a mucocutaneous junction. Sometimes we think about that. Perineal and muzzle, those can be a little more invasive. I bump them up. Even if they're grade 1, I treat them as grade 2, and I treat the grade 2s as grade 3s. I've already gone over some of this already. The gist of it is it's a grade 2 with radiation. At 1 and 2 years, 95% don't recur. And at 1 year, 90% don't recur. If you will get about, depending on your read, a 17 to 56% local recurrence with incomplete excision alone. So yes, you could believe the really good surgical papers that say, no, it shouldn't come back. It's like less than a 15%. Or you can read some of the other papers that say it's like close to 50%. So either which way, I think it's worth offering. So we said this. So now we get into, well, what happens if it's in the lymph node? I removed the lymph node, or I got really narrow margins, and it's a grade 2 because those are the majority of them. I aspirated the lymph node at staging. Now what? It's in the lymph node, or you get something that says it's most likely in the lymph node. Do we not move forward with surgery? Do we not treat with radiation? What do we do? So in this case, there was a great study by Chaffin back in 2002, and long-term control is actually pretty fantastic regardless if it's in the one draining lymph node or not. Disease-free interval of 41 months. Now, what I do as well is if it's in the lymph node in my world, it's definitely worth offering systemic chemotherapy, because who says that it stopped at that lymph node? We'll ignore the fact that the paper says 41 months and they didn't use chemotherapy. However, to me, it just seems like a really good idea to do chemo as well and cover your bases. If you need to phrase it, I would phrase it as chemotherapy insurance, because truly we want to at least offer that. So now we get into grade 3s, and grade 3s are not fun, unfortunately, but there are some things that we can do about it. There was a study out of JAVMA in 2004 with a remission of 27 months for 31 of those dogs that were treated with surgery and radiation. In addition, I always recommend chemotherapy. They did it in that paper. Do chemotherapy. So it does somewhat call into question the results. Maybe it was a little bit optimistic, based on my experience, definitely optimistic, but it is there nonetheless. So I always recommend chemotherapy. Also, GI protectives, antihistamines, all those dogs should be on Pepcid and Benadryl over the counter for that. Kelly Hume, back in 2011, did publish something to say that 27 of the 43 dogs failed due to local disease recurrence or regional lymph node metastasis. So what I take from that paper and what I see all the time is if it's a grade 3 locally, you really have to be careful because local regionally, you're going to have issues. So if it's on the leg, the pelvic leg distally, really watch that lymph node. Or if you really want to be aggressive, just take it out. That's another option as well. So mast cell tumors and chemotherapy. High grade 2, grade 3, metastatic disease, mucocutaneous, muzzle pans, inguinal, definitely they should be seeing chemotherapy. Common agents that we'll find, vinblastine, CCNU, tyrosine kinase inhibitors, and prednisone. And there are other options as well, but that definitely is worth an opinion from your local medical oncologist, or here at Animal Cancer Care. We always can do phone consults as well. So mast cell tumors, there's a lot of different literature, just like radiation, just like surgery. What I was having a conversation with one of my colleagues is, we used to quote a lot of statistics, and it's nice to say, well, the median survival was ABC, and in this study, da-da-da-da-da-da. And, we sound really smart, but at the end of the day, as I said, our data acquiring could definitely use a little bit of work. When I speak to clients, I say, look, there's data out there, but following just the principles of how to treat a tumor, in my mind, if you haven't got it all with surgery, you're going to radiate it. If it's something that likes to spread or we're worried about, we're going to do chemotherapy. And that's the best that we can do. There's no guarantee one way or the other. Your dog could live for the rest of his or her life, but at the same time, we can do everything. And unfortunately, cancer will be cancer. So this is the best that we can do. And so chemotherapy, definitely something that I would recommend in the circumstances that I've said. I've listed some responses here. I say 40 to 60% response, sometimes higher, sometimes lower. And I leave it at that. And then I refer them to our medical oncologists as well. So mast cell tumors, the other thing that I will say is that we have Palladia, Kineret as well, Mastininib. I don't know if it's that easy to get anymore, but it is an option, and that is something that we reach for. I'm a big advocate of getting a medical oncologist's advice for using the tyrosine kinase inhibitors. A lot of people can use them now. You got to be careful. You really do. I don't think it's as safe as we are led to believe. Just anybody can give it and any vet can do it. I think that there's a lot of bad things that can happen that we've seen. And if you don't have a lot of experience or you don't want to get in trouble, it's really worth getting an opinion from someone who literally does that every single day. I don't even put my own dogs on Palladia. I refer them to the medical oncologist. Now, I've done chemotherapy for years, but I'm a radiation oncologist, and we have medical oncologists. Why would I do that if literally they can at least see somebody who is, that's all they do. So big plug for medical oncologists. But that being said, there's things that I would never do GP-wise, and so I stay out of that realm. In general, I just haven't done it for years, and I'm not as good as you guys are. So just keep in mind, when you hear Palladia, anybody can use Palladia. I've seen some dogs who have like grade 1 tumors who've been put on Palladia and sent to me. It's a very difficult conversation, a lot of different obstacles to avoid, to put forth that it wasn't wrong to use Palladia in those circumstances. So, call us, we can help you out. So cats. Mast cell tumors in cats, generally, we don't worry about them, but we do get some, unfortunately, that don't really read the book. So as far as mast cell tumors in cats, it's mainly cutaneous. It's the second most common tumor in the skin of cats. Again, we don't know what causes it. Metastatic rate, generally they don't met, but they're I put here 0 to 22% because sometimes there's a small population of them that can be a little bit more invasive. It's more common to see these guys on the head and neck. As I said, there's two different forms that we go for: the mastocytic and the histiocytic. Mastocytic is what we usually see, and they're very similar in some degree to dogs. And then you have the histiocytic. I don't think I've really seen a histiocytic that I can remember. But that being said, I'm sure it will happen one of these days. Those are for young cats. Siamese are more predisposed. They will regress 4 to 24 months later. And as far as treatment is concerned, I usually stage them just because we don't know who that subpopulation of the ones that are going to be more invasive are. So definitely worth doing abdominal ultrasound, definitely worth doing a spleen and liver aspirate. Some may think that that's a little overkill, but I think that I do it, at least I offer it. And then we just cut them off. We don't really need margins in these. It's not as important for these. So if you get margins, great. Even if you don't get it, probably it's not going to come back. Soft tissue sarcomas. So soft tissue sarcomas, I actually really like treating in dogs. I know it's horrible to say I have more of a favorite, but this is one of my favorites. And it's just because we can do a lot about these and we can really help out. So they arise from connective tissue, muscle, nervous tissue. They think it's a abnormal production of some of these cells. It is in an uncontrollable manner. They're just growing out of control and they're not listening to the body's natural signals to stop dividing. So we have these tissues all through our body, and so they can develop pretty much anywhere. Soft tissue sarcomas will make up about 15% of the cancers of the skin. So this is not a common presentation seeing this, although I can swear this thing grew overnight, Doc. Really it did. But when we see these, they are surrounded by, or most of the time, they're surrounded by a pseudocapsule of poorly defined tissue. It looks like when you go in, you're just going to get it peeled right out. Well, unfortunately, they don't do that. A lot of times they are pretty connected underlying. They got, unfortunately, a lot of tendrils that are there. When I talk about soft tissue sarcomas, I lump them all together. When I see everything mixed here, fibrosarcs, neurosarcs, liposarcs, and angiopericytarc. Then we have myxosarcomas, which are the tumors that spit at you. They're mucus producing, chondrosarcomas, and just general spindle cell tumors. So in general, those all are soft tissue sarcomas, except for the lowest one, which is spindle cell tumors. That's actually like saying I have a soft tissue sarcoma, and that needs to be worked out a little bit more. That jumped in there somehow, somewhere. Anyway, but the ones above, they all act the same generally. So their behavior, they're locally invasive and depends on their grade, their metastatic grade. There's two different grading schemes. It used to be that it was just like low or high. And now, well, not now, it's been like now since, when did she do her paper? Back in 1997, Barb did it. So she divided into low, intermediate, and high. And so when I talk to clients, what I tell them is the low and intermediate are locally going to be invasive and generally have a low rate of metastatic spread. If you look at that, the metastatic rate for the low one is 13%, while the intermediate one is 7%. So anyway, but what we do take from that is that the metastatic rate for high grade is up to a 40% metastatic rate. So what I say differentiates the intermediate from the low is their local disease recurrence. Definitely intermediates are way more locally invasive than your low grades. And if you don't get margins on that thing is most likely coming back. Prognostic factors, grade, mitotic index, both it's been consistent as far as the different papers. Margins, well, we know margins, frankly, incomplete margins, it's 10 times more likely to recur. In my mind, for an intermediate, it is going to recur until proven otherwise. And same thing with if you get narrow margins too. If it's intermediate, if you're not getting 1 centimeter or 1 tissue plane deep, that thing's coming back within 6 months. So location, soft tissue sarcomas in the mouth, they have a worse prognosis, unfortunately. So what to do for staging? So same thing to some degree from what I said for mast cell tumors. The only real change here is that we will do thoracic radiographs and say plus or minus an abdominal ultrasound. It depends where it is. If it's on the back half of the body, definitely an abdominal ultrasound. If it's on the front half of the body, plus or minus. It's extra credit. It's not a bad thing to do. I feel better knowing if I'm going to do radiation that there's nothing in the belly or nothing else in the belly that's not related to the tumor. So first things first, an aspirate. The next thing would be a biopsy. I usually aspirate them if I get something that says soft tissue sarcoma. At that point in time, my biopsy, really depending on location, a lot of times is excisional. Unless it's something that I know that margins can be obtained, then it's different. Now, if it's on a limb, it doesn't matter what I'm doing. I'm not going to get margins unless I take that limb off. Those are great excisional biopsies. So true cut versus punch biopsy, excisional versus excisional. It's, again, location dependent. So staging, CBC, Kim, urinalysis. Don't forget your urinalysis. 3-view thorax, radiographs. You know, it's interesting. I notice this all the time. I'm boarded through the American College of Veterinary Radiology. I say that not to boast. I say that because I get every single one of my x-rays read by a radiologist, every single one. I don't want to miss anything. So I really put that out there. We all should be doing that, not to keep them in business, but because they're going to see something that we're not. And the worst and most embarrassing thing is to go through, do therapy, do everything, and then all of a sudden, the dog explodes in metastatic disease, and they go back and they look at that x-ray that you or I took that we didn't get read by a radiologist. And lo and behold, there was that small little opacity in the caudal lung field. Whoops. So definitely get it read by a radiologist. Aspirates of the draining lymph nodes, same thing. Depends on where it is, but definitely do that. And abdominal ultrasound, as I said, if this tumor falls on the caudal half of the body, definitely. If it's on the cranial body half of the body, then unless you have another reason to do it, you know, elevated liver values, you're worried about something else, or just the owner really wants to be thorough, then do it. So canine soft tissue sarcomas, treatment. So like everything, if it has not metastasized, treatment of choice is surgery. Surgery, surgery, surgery. If you can get margins, awesome. If you can't get margins and it's a little bit too big of a surgery for you, feel free to consult your local surgeon. They probably will definitely want to do it. So in JAVMA 1997, the disease-free interval was 1850 if incomplete surgical excision. The median disease-free interval was not reached if it was complete. So, you know, let's get margins if we can. Recurrence rate, 2% versus 30%. And again, if you get margins, you have a higher chance of this thing not coming back. Ideally, wide surgical margins. That's from 1997. I would wish that they had quantified their margins a little better, but that, as I said, is a problem with our data acquisition in the veterinary field. So we'll talk about radiation because that's what I do and that's what I love. So soft tissue sarcomas, definitely one of the most common types of radiation or the tumors that I radiate. This is a drawing of what I used to do most of the time. I don't do it anymore in these guys because I have stereotactic radiosurgery or body radiosurgery. So this is a picture of what we used to do, which is 3 centimeters of margins all the way around. That dog will go on to develop some acute radiation side effects. Most likely, he'll get desquamation, which looks like a rug burn, and that's the old way of doing it. We don't do that anymore, at least I don't. So if surgery is not an option, then we can also do definitive radiation therapy alone by itself, and that also has pretty good results as well. And then for my high-grade tumors, definitely offer systemic chemotherapy as well. Surgery and radiation therapy, here's some old papers. I'll summarize it. At 1 and 2 years, what I tell owners is 86% of dogs will not get their tumor back. And 5 years, 76% won't have their tumor come back when we do radiation and surgery. I will jump ahead and say with stereotactic radiosurgery, it's less than 1%. Much better. So say we can't do surgery. So then we do radiation alone. And if we do conventional palliative radiation therapy, 67% of them will have control at a year and 33% at 2 years, according to this paper. And then stereotactic radiosurgery, there now is published information to say if you can't get it surgically, you go to stereotactic, and lo and behold, you're going to get a good result. So at about 2 years, what this paper found is that roughly at 2 years, it was controlled. It was the median disease-free interval was 2 years. If you took into consideration all causes of death, if it was tumor-related death, only 4 years. I don't go with the whole tumor-related death. I think that you have to factor into everything. So, scars and radiation therapy. This changed my way of practicing, changed the fact that I don't need to give dogs horrible side effects. It made me very sad having to do that. And so, as I've alluded to, now we do scars with radiation therapy with stereotactic. I'll spare about 3 to 4 millimeters of the topmost layer of skin. I'll treat about 1 to 1.5 centimeters of the underlying tumor bed, and I'll do it in 1 or 2 fractions. So realistically, they're coming in twice, one for the CT, and then majority of them once for the radiation. And I'm not going to give them side effects except for a little bit of alopecia. And you know what? My wife loves alopecia, thank God. So I think the owners will also as well. So personally, I've treated, this is an old slide, I'm probably over 9,000 cases stereotactically in the 10 or so years that I've been doing it. I'm at thousands right now of skin cases, and I can count on one hand for soft tissue sarcomas, my recurrences, which doesn't mean that they won't come back like, tomorrow in the next month, I'll get a bunch of them. But for right now, it's doing great. And the clients are so much happier as well. So soft tissue sarcomas as well. I just named some things for palliative radiation therapy as well for that. So if you can't surgically take it out and they can't afford definitive treatment, palliative radiation is great. What I tell people is that we'll probably keep this thing stable for about 9 months. And reasons why we won't do definitive, it's like a 15-year-old dog. That's one option or one reason. The other is just money. At the end of the day, financially, it's not feasible for a lot of owners, but at least we have palliative and we can offer that. So cat soft tissue sarcomas, most common are vaccine associated. It's very rare that we don't see anything that's not vaccine associated. So the incidence is 1 in 15,000. That was in 2002, a study. It is thought to be FELV and rabies associated, the vaccines at least. Metastatic rate, I tell people about up to 25%. Couple of things that are prognostic. The main thing is margins, which is related to the institution doing surgery. I cannot tell you how many cases in my career I've had to jump through political hoops not to insinuate that the vet shouldn't have done the surgery for the cat and it should have just biopsied. There's vaccine sarcoma groups, there are chats, there's everything out there. Even Merck was giving a discount because of their vaccine for a while. I don't know if they're still doing it, but my take-home message to everybody else is if you have a mass in a cat, don't try to remove it. Biopsy it first, because if it does come back as a vaccine-associated sarcoma and they were willing to do radiation, you have just taken their disease-free interval from 33 months to 11 months. And the clients will know that. Obviously, I never throw anybody under the bus. I refuse to answer anything like that, and I play it pretty well. So surgery in some paper, if we could, it's the best possible treatment if you could get margins. So on our distal limbs, those are great to amputate if you can and they don't want to do anything else. But if it's anywhere else on the body, I don't go to surgery first. I'm more of an older guy as far as the literature is concerned in my experience. I go to radiation first. And the reason being is in that picture, you can see that mass. So if you do surgery first and you don't get margins, that radiation field there, that's probably about 15 centimeters, now jumps to about 30 centimeters, which is half the cat. So you want to do radiation first. So number one, you get rid of all of those residual tendrils. And number two, when the surgeon goes for it, they're going to hopefully get it and get those margins. So I always recommend if they're going to do radiation first. And in this case, we don't do stereotactic with surgery. We do ideally conventional radiation or intensity modulated radiation therapy. It's conventional, just with a fancy name. And we do it the standard way. So as I said, the time to first interval here, if you don't get margins, it's 4 to 12 months versus if you get margins, it's 23 to 30 months and 33 months. And see, there's a lot of different papers that have come up with that. So that is something that we see. So there's one paper out there that did have non-surgical masses, and these guys did do stereotactic radiosurgery. It was, flipping a coin. The survival ranges were 4 to 40 months. So the gist of it is, if you can't remove it surgically, try stereotactic, and we can hopefully get some form of a response. If they can't afford stereotactic and it's non-surgical and they don't want to do anything like that, then palliative radiation is great. They actually respond really well. And there was a great paper combining chemotherapy and radiation. And frankly, my friend Miriam Kleider, one of my residence mates, did get about 7.9 months when she combined palliative radiation and chemotherapy. So there's definitely some literature about chemo alone. If you don't have radiation therapy, or they don't want to come, they don't want to schlep from, Boca all the way down to Fort Lauderdale. Sorry, I'm from LA. Everything's 45 minutes away. But that being said, chemotherapy alone is also something that can be used depending on what you read. It's worth a try, 50% in some papers as far as response. And I believe I have come almost to the end of it, and I would love to welcome some questions. That was Vinny. That was my rescue Doberman that turned out to be quite a handful, but cute nonetheless.
I love the picture, Dr. Lyons, Mr. Vinny the Doberman. So thank you so much. That was really quite a lot of information and very informative. So thank you. And we do have some questions. So I'm going to just jump right in, okay? If you're ready.
Definitely.
Oh, and also thank you for the plug for the medical oncologists. So really good. Loved it. So, all right. So first question, it's about mast cell tumor. And I had read that the size of the tumor plays a role with prognosis. Is that still true?
It's a great question. Depends on what you read and depends on what you see in real life. Yeah, it goes to, for me at least, if there's a really large, huge tumor and it's red and it's angry and, it's big, then I'm probably going to say yes in some circumstances. But again, we have those other ones that are big, nasty, red, and you treat them and they go away. So the jury is out. It doesn't change what I do at all. I think it's academic at the end of the day. And that's what I would tell my clients who've been, going on Dr. Google. I would say it's not going to really change what we do. And there's no real great literature for that. The data acquisition, like everything, is not as good as it could be.
Okay. Yeah.
What's your experience, Dr. Gray? I'm curious because you see the ones that I don't, and you're an amazing medical oncologist. So I'm curious as well. What do you think?
Another nice plug. I love it. I find that the really large ones, my issue is that a lot of times they've been there. Well, not a lot. Sometimes they've been there for a long time. And then I've got to deal with other things like the lymph node is involved and, there's metastatic disease. Now, on the flip side, if they're a high grade tumor and they grew really, really quickly because they're such a high grade tumor, then I've got more a chance of actually shrinking those with chemo because the rate of cell division is so high. I'm imagining you would feel the same way about radiation therapy. The cell division rate is so high that it does work. So, I think that when they're not surgically resectable, like you had said in your lecture, when you can't get any sort of margin and they're non-resectable, that's a poor prognostic indicator. So, okay. Cost. Let's talk about the cost of stereotactic radiation therapy compared to the cost of, let's say, month-long radiation therapy, the conventional.
Sure. So they're equivalent at the end of the day. We wanted to make it that cost should not be a factor at the best medicine. And so, we all got together and came out with the fact that, again, we don't want it to be an issue. So what I would find, though, is as far as aftercare is concerned, even though the actual procedures are similar as far as the initial cost, sometimes if they do get some acute radiation side effects, there's some medications involved. There's maybe coming a little bit to the hospital more just to double check and make sure it truly is okay, even though the radiation oncologist said that that's normal. Still, we want to make sure. So it's very equivalent at the end of the day, I would say. And I think personally, look, if I took a month off to have to schlep my dog to the clinic, or my wife had to take a little bit of work off, I would actually argue that it's probably more just from that cost involved, just from both the financial and just a mental, for sure. Florida drivers are it's an extreme sport driving here. I'm from California and I drove a motorcycle for a while and I'm scared to drive here. So, there is that.
Right. So, yeah, like Dr. Lyons said, we did try to sort of cost it, and radiation, whatever. When I talk to clients, I tell them, listen, no matter how you slice it, radiation therapy is expensive. I mean, it just is. All of the equipment, and we have a physicist and a dosimetrist and a therapist and Dr. Lyons. There's just a million different people and expertise that goes into this. But just as a benchmark, for conventional radiation therapy, so that would be, let's say 21 treatments or, 3+ weeks of radiation therapy for a mast cell tumor, that's going to run somewhere around $6,000. That is not, we don't have to do a CT when we do that. So, and I know I'm speaking for you, Dr. Lyons, but I don't want to say it's point and shoot, but it's kind of point and shoot. Okay. So stereotactic, the way I think about it and the way I explain it to people, we have to do what's called a tumor mapping CT scan. So you have to actually map out exactly where that tumor was located. And I talked to them about, the little tendrils that sort of extend out from the primary tumor. So we do a CAT scan, we load that 3-dimensional information into the treatment planning computer, and a stereotactic treatment plan is developed. And so that's the one treatment that Dr. Lyons is talking about. With the scan, the tumor mapping, and the treatment, between 1 and 3 treatments, we're looking at about $9,000 to do that. So that's just kind of some benchmarks for when you're talking to your clients. When Dr. Lyons had said, the ability to treat a scar with 1 or 2 treatments of stereotactic radiation therapy has really changed the way he practices, I would say for me as well, I would agree with that. So when I've got an old dog, like a 13-year-old lab that had intermediate soft tissue sarcoma on the stifle, and, of course, we got an incomplete excision there, and I'm able to, for that old dog, not put that dog under anesthesia 20 times and do 1 dose of stereotactic, basically cure that dog. That for me is a really great option to be able to offer. So I don't know if you want to comment on that anymore, but.
Yeah, definitely. I think also the thing that's changing for me is that we get to chemo a lot sooner for those grade 3s. It used to be just a scary thing that while we were treating the month-long for the grade 3s or the high-grade 2 mast cell tumors, or even the high-grade soft tissue sarcomas, there is always some of those that we lost the battle by the time we got to chemo. And so for me, it's something that I can get them to medical therapy a lot faster, and they're going to have a better prognosis, in my opinion, if we could zap what's on there on the leg or whatever it may be, and now we get him to systemic, and then we don't lose the battle systemically after having put him through a whole month of radiation and potential side effects. That's heartbreaking when that happens. So we minimize that now.
Right, right. Great point about getting to the systemic therapy quicker. So true. Here's another one. And so how much is a tumor decreased in size by typical radiation therapy? So let me just maybe make that, I'm going to give you two scenarios. So if you have a non-resectable mast cell tumor, large mast cell tumor, how much does that shrink with radiation therapy?
Great question. Assumption on that one is it's already seen prednisone, it's already seen chemo, and now we're dealing with it in a palliative setting. So I've had them shrink 80, 90%, go away entirely. For me, frankly, I'm happy if the thing stays stable and doesn't grow. So for me, I set my clients up for expectations of, let's hopefully stop this thing in its tracks. And if it shrinks, even more positive. And it really is dependent on each of the tumors. We don't know. We don't know. But I've had it happen always. Most of the time they do shrink because they're pretty radiosensitive in it. And the other thing I just thought of is palliative radiation is around $3,500 to do. So if they don't want to do conventional or stereotactic or IMRT or the high dose radiation, then low dose radiation is around $3,500 about.
Right, right. Great point. Yes. And we tried to make it so that there is an option, like people have an option. And I find too, I always tell clients, hey, look, with palliative radiation therapy, it's going to stay stable. And that's what I expect too. But a lot of times I really am pleasantly surprised because they do shrink. And that's for a mast cell tumor. What do you think about a soft tissue sarcoma though? So a large soft tissue sarcoma, maybe like some of those pictures that you showed us, with
Yeah.
palliative or stereotactic, like does it actually shrink?
So I think it shrinks a little bit. I do. I don't think you're going to get like, a 50 to 80% reduction in size typically. I think what you'll get is about anywhere between a 25% reduction to 50% or just stable disease. And that thing will just be there for hopefully the rest of the dog's life, since most of these guys are 12 or 11 anyway when they present. So, and it's another thing I didn't mention on the literature. You don't see these really long survivals on these things because the majority of these guys get tumors at 11 or 12. And so what I tell my clients is, you got a median survival of 1.5 or 2 or 3 years. Well, yeah, that's pretty good. I mean, for your 11-year-old, thank God we don't have a study of a bunch of 6-year-old dogs with tumors that we can pull from. So, keep that in mind when you read some of the literature as well.
Right, right. Thank you. So I'm just sort of looking through the questions. I think we got to everything. There are a few questions about Stelfonta. We did not cover Stelfonta tonight. It's a little out of, I think, Dr. Lyons, kind of something that you don't do, correct, Stelfonta?
It's not something that I do. I usually refer them over to you guys. And truth be told, I completely forgot to put a Stelfonta slide in here. So, keep in touch with Dr. Correa and our group, and they definitely can give you a little bit more, more information about it. But basically, if it doesn't do chemo, the dog doesn't do surgery, doesn't do radiation therapy, then, or if they want to just try something different, Stelfonta is a great option to do. And that's me handing it off.
I'm happy to speak to it just a little bit. So we are doing Stelfonta, and I just did one about a week ago on a digit. So about a 3 centimeter by 2 centimeter mast cell tumor on a digit. Administered the Stelfonta. My experience is that it works. Sometimes you have to go back and give a second treatment at day 28. In this particular dog, I just gave one treatment. Actually, it was 4 weeks ago. I gave one treatment, and then on day 28, came back. The tumor was gone. The whole area had healed. My issue with Stelfonta has been that they recur. Like when you look at the studies, they're not supposed to recur at least for a year. And I'm getting recurrence earlier than that year. I don't know if that's just the population of dogs that I'm doing, because most of them are interdigital or digit. So I'm seeing that. So that's one thing. I'm happy to talk to you all about that more. But it kind of like what Dr. Lyons said. I prefer surgery, number one option, and then followed by radiation or chemo. If it's non-resectable and we can't do anything else, then I'll go to Stelfonta. All right, let me just check Dr. Lyons real quick. I think we're just about out of time, but let me just make sure that I didn't have any questions sort of sneak in here. All right, that looks like we are done for the evening. Everybody, thank you so much for being with us, for attending. We really enjoyed it, and I hope everybody has a wonderful evening and wonderful fall. And remember, look for the invitation for our book signing open house event in our Orlando and Fort Lauderdale offices. And Dr. Lyons, so great job.
Thank you.
Thank you. Thank you. Take care, everybody.